Respectful of the time we're going to allocate for this, and that we can move through it very quickly. With that, can we have the roll call, please?
Senator Rocky Adams. Senator Chambers Armstrong. Senator Berg. Present. Senator Carroll. Senator Douglas.
Present.
Senator Elkins. Present. Senator Funky Fromeyer. Present. Senator Nemes.
Present.
Senator Tishner. Present. Senator Wise. Representative Bentley. Representative Bratcher. Representative Bray.
Present.
Representative Burke. Here. Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Dotson.
Present.
Representative Duvall.
Present.
Representative Frazier Gordon.
Yes, ma'am.
Representative Justice. Representative Neighbors.
Here.
Representative Rayburn. Representative Raymer.
Here.
Representative Riley. Representative Rorks. Representative Sharp. Representative Wilner.
Here.
Representative Witten.
Here.
Co-Chair Mosier. Chairman Meredith.
Present. We do have a quorum and duly constituted to conduct business. For our presenters, you notice again we have a very lengthy agenda. I would respectfully ask if you could keep your presentation about 15 minutes so we can leave about 5 minutes for questions so we can move on through this agenda very quickly. Our first order of business is approval of minutes, which were previously distributed. Is there a motion to approve those? Is there a motion and a second? All those in favor vote aye. Any opposition, by like sign. There being none, minutes are approved. Thank you. Our first presentation is from the regarding paramedic and EMT staffing shortages. If our presenters are here, I'd ask you to come forward. Good to see you, gentlemen. If you would, please identify yourself for the record and feel free to proceed with your presentation.
Good morning, sir. My name is John Holder, the current chair of the Kentucky Board of EMS, and I have with me Director Eddie Sloan. He's the executive director for the Kentucky Board of EMS.
Please make sure your microphone is on.
Yes.
The green light should be lit.
It is. It's illuminating.
Okay.
Can you hear me okay?
Pull it up a little bit closer. I think
Okay.
it'll help you.
There we go.
There you
Better?
go. Thank you.
Excellent.
Yes.
Excellent. Good morning. We appreciate the opportunity to help and appreciate your time. We will start with a brief update on the staffing shortages that EMS has been experiencing. Unfortunately, I wish I had a better report for you, but the staffing shortages do persist. The findings of the EMS Legislative Task Force from a couple years ago remain largely unchanged, unfortunately. The EMS in Kentucky has an attrition rate of 21% among our providers right now. That means for us, 2 out of 10 of our providers will not return and will not certify again next year. That trend has remained true, and we can kind of count on that, unfortunately. Of the ones that remain, only 40% of our providers are now affiliated with a service. So that means that less than half of those who are certified are actually going to work on an ambulance and treat members of their community. We lose more paramedics every year than we gain, unfortunately, and there are multiple reasons for that I'll get into. But basically, we're hemorrhaging providers. We're losing more paramedics than we can replace. On top of that, our call volume is up 30,000 runs from the time before the EMS task force started to look at this, which means not only are we losing providers, but the supply is dropping and demand is increasing. I think the most concerning thing for us right now, and Eddie can attest to this as well, Mr. Sloan can attest to this, is we're receiving regular calls from EMS services who are saying, gentlemen, we're having to self-report that we cannot meet the staffing requirement as set by regulation, which means that they don't have enough paramedics to staff their ambulances. That's concerning. What's more concerning, however, is that it wasn't too long ago that the Kentucky Board of EMS actually had to reduce that requirement in order for services to keep their doors open. And I hate to sit here and tell you this, but we had to reduce that to 1 paramedic per service. And what that meant was you only had to have 1 paramedic on duty, regardless of the size of your service, in order to keep your ALS, service going. And we're still receiving calls from folks who are saying we can't do that. We can't find 1. At our last board meeting, as a matter of fact, we are actually discussing options to allow for other service providers such as advanced EMTs and things like that to fill that need in the meantime until we can fix this staffing shortage. I say shortage, we use that term a lot. It truly is a crisis. I mean, we have services that are going to shut down if we can't find a solution to this problem. So it's definitely concerning. So as I mentioned, multiple pieces to that puzzle. What are they? The Kentucky Office of Rural Health did a pretty robust survey of pre-hospital providers to try to figure out what the issues were. Of course, compensation was at the top of that list. These folks aren't being compensated what they're worth, to be honest. There's a direct correlation between that and just abysmal reimbursement. These EMS services are losing money when they make ambulance runs, which is hard. But the cost, you have it in your packet. You've got a lot of data there in front of you, but the cost is a little over $700 on average to make an ambulance run, and we're losing hundreds of dollars per ambulance run, depending on the payer mix. So a lot of folks will tell you, "Oh, we'll just pay them more. We wish we could, and we would if we could." But with reimbursement the way it is, the pot is just not big enough to draw any more funds out of, which leads me into the trouble with education. Another finding was access to education, specifically in the rural parts of our state, is challenging. There's such a shortage of paramedics that other provider levels are having to fill in. It's difficult for them to leave to travel for hours to go to a paramedic class. We do have a few across the state of Kentucky that are doing a fantastic job. I don't want to disparage the quality of their service, but the men and women out there educating pre-hospital providers are doing a fantastic job. There's just not enough of them. And so especially in our rural parts of the state, our providers are having to travel hours multiple times a week to try to find this education, and they're either unwilling or unable to do it in a lot of cases because they're needed at home. So what has been done to try to fix this thus far? The Kentucky Board of EMS has tried to remove as many barriers as we could in good conscience for educators to create more educators across the state. We've done that. We've removed licensing fees for newly certified providers, which of course, was a little bit of a hit to the budget, but we were trying to bring as many as we could in, so it's actually free to be certified as a pre-hospital provider in the state of Kentucky right now. We've also opened reciprocity for providers from other states who have met Kentucky standards. So if you go through a program in another state, but you've met our standards, it's open reciprocity if anybody wants to come to Kentucky and work. We're pretty proud of that. We've decreased the number of advanced providers required to maintain an ALS coverage like I spoke before. That was a very difficult decision, I'm not going to lie, but we needed to do it in order to keep services open. So as of today, you just need one paramedic. And we've also sought out opportunities to encourage better reimbursement rates and also reimbursement for treatment in place, which we've had some success with. As many of you know, most often if we don't transport a patient, there is no reimbursement for that. So, and also last session with the passage of House Bill 484, we worked very closely with Representative Frazier Gordon to get that passed. We very, very much appreciate her efforts on that. That bill was designed to address these specific issues. We started by looking at the minimum number of paramedics that we needed to infuse into the Commonwealth to make ends meet, and then how many TEIs or training institutions we would need to stand up across the state in kind of the underserved areas to make that happen. That's what that bill was designed to do. We were very happy to see it pass. We think it has the potential to do great things. Unfortunately, without some type of funding stream, it's difficult for that bill to be effective for us, but we still are very hopeful for that. So, again, I wish I had a much better report to give you, but that's the reality of the situation for pre-hospital care in the state of Kentucky at this time.
Well, excellent report, and I don't have any problem hearing the reality of the situation because that's what we're here to do and try
Yes,
to
sir.
address those type of issues.
Yes, sir.
Senator Berg, you have a question?
Thank you, Mr. Chairman. Thank you for your presentation, even if it's a little not on the most optimal side.
Yes, ma'am.
Two things. One, I mean, you know this. I don't have to tell you this, but sending a paramedic out alone is so far from optimal that I can't even, I mean, I don't ever want to be in an emergency situation as a provider unsupported by yourself. You can't do anything. 4 years ago, I proposed a bill. We, at that time, and I believe we still are, train some of our incarcerated citizens in the state as EMTs. And while they're working, while they are incarcerated, they are allowed to work. They transport patients from the hospitals, from the jails to the hospitals and all that stuff. But the day they are released, they lose their license because they have a conviction on their record. And, this is potentially 6 or 7 EMTs that we're turning out a year that could go straight into employment. From the day they get discharged, we could have good, honest work for them. They've already been selected. They've already been trained. This is just a suggestion. I made it years ago. Nobody wanted to listen to it because these people have felony convictions. But the truth is, you have a right to make up a debt to society. So thank you.
Yes, ma'am.
Thank you. Senator Funky Fromeyer.
Thank you for bringing this awareness to our attention. Slide 5 talks about affiliation and retention. I'm not understanding that there are 4,292 licensed and 2,474 working.
Yes, ma'am. That's a very, very good point. So basically, what's happening is we have providers that are leaving the workforce for multiple reasons. I guess to summarize, we're a little behind the 8 ball. So what's happening is there aren't enough paramedics to fill this need. So the ones that do exist are having to shoulder a large burden, and we're losing more and more of them. So what's happening is we don't have enough. So they've got a paramedic certification. They're leaving the workforce. They're getting off the ambulance for multiple reasons. And from my conversations with a lot of these medics, they just can't stretch this thin anymore. I know personally from the service that I manage, one of my best care providers left to go sell air conditioner units commercially. And when I asked him why, he stood there and got choked up, and he said, I can't do it anymore. I need to spend some more time with my kids. I'm not making any money. This is a hard job. I've got to go elsewhere. His passion was for helping people in his community, but he wasn't able to do it. And we're seeing more and more of that because that need stays where it's at no matter how many providers we have. So the few that are left are trying to stretch thin to make ends meet.
Thank you.
Yes, ma'am.
We have 3 more questions in about 6 minutes to conclude this portion, so I'd ask everybody to be very brief, very concise if you can. Representative Wilner.
Thank you, Mr. Chairman. Thank you for the presentation. It's grim, but we do need to hear this. I guess I have a bunch of questions, but I know we need to make it short.
Sure.
What do you need from us to increase the reimbursement rates? And how, I know this was something that was talked about in the EMS task force a couple years ago. How do we make sure that there's reimbursement if you're able to provide treatment on site?
Yes, ma'am.
And then that keeps people out of the hospital and that reduces costs overall, but you guys don't get paid.
Right.
What do you need from this body to increase those reimbursements and to make sure that you're being reimbursed even when there's no transportation?
That's an excellent question and an excellent point. I couldn't agree with you more. I think treatment in place, everybody wins. The patient doesn't have to go to the hospital unnecessarily. The hospital doesn't have, to incur costs that we can handle in the field. Basically, we would need support from you to increase those reimbursement rates. We're moving our advanced practice paramedics forward, including community paramedics and mobile integrated health programs. Looking forward in the very near future, we're going to be looking for avenues for those folks to be reimbursed when they go out and provide that care. So we would absolutely love to have some support on that. Yes, ma'am.
Thank you. Representative Burke.
And thank you all for your presentation. It sounds to me like you need several things. Am I understanding correctly?
Yes, ma'am.
One of the bills that I had heard earlier in the interim relates to providing workers' comp for first responders who experience psychological injuries as a result of their service. Is this something that would enhance your ability to retain workers?
Yes, ma'am. Absolutely. I think that's a major cause for folks leaving the workforce. As you can imagine, that's a huge burden for these folks to bear emotionally, and that's something that we haven't done the best job of addressing in the past. who helps the helpers, and so a lot of us don't do a great job of asking for help because we're the ones providing that. So yes, ma'am, I think that would be hugely beneficial.
Thank you so much.
Yes, ma'am.
Last question for Representative Callaway.
Thank you, Chairman. Thank you for your presentation. I'm sorry having to deal with all this. And my question, Representative Wilner asked, but I want to push just a little bit harder.
Sure.
When you say support for somebody who's fairly new, tell me what that looks like.
Well, I think part of that support is to make sure that we at least break even, right? Because the runs that folks are losing money on are the 911 calls. Those are the calls that you don't have the opportunity to pre-certify. You don't have the opportunity to say, how can we get a payer? Can we make sure this individual has pay someplace? And those 911, and when you think about your rural counties, and so it's in our urban areas, perhaps we can tax ourselves to a point that we can share those costs a bit. When we get to our rural areas of Kentucky, providing 911 services is a losing proposition all the way down. And at the end of the day, you got to be able to break even. You got to be you've got to be out of the red into the black. And so I think that's the key support, is to look and see what an agency allowed them to bill for what they're out on that run. A cardiac monitor, many of you in the healthcare field, but a cardiac monitor now is $65,000 if you buy a new cardiac monitor. And so you take that $65,000, when you look at that on what the Medicaid rate is reimbursing, just for the cardiac monitor, you're talking about 600 transports just to pay for your monitor. 6,000 transports to pay for your monitor. A vehicle now. We've all seen the inflation of vehicles, right? And simply stated, Medicare hasn't kept up. Medicaid has not kept up with the inflation that we saw. Pre-pandemic, it was nothing to see an ambulance, maybe $175,000. There are manufacturers now that have canceled their orders of folks that had orders that they put in during the inflation. They said, you can go to a new seller or a new company, do whatever you want to do, but we're not going to honor this contract that we've signed with you. We will lose money on it. So when you look at those numbers, especially these poor rural counties are trying to keep up and provide a 911 service, it can't be done on the current rate. So the bottom line is, we will work with you, but let's come up with what it truly takes to break even, and that's where we need to be to survive.
We have a minute left. I'm going to allow Senator Carroll to ask a question.
Thank you, Mr. Chairman. Briefly, can you all talk about the private insurance side of it, the issues you have with them, the rates they...
It's better, but it's not good. We're not I think it's tough to say that on many of your 911, again, speaking on the 911 runs, that you're probably breaking even on those when you consider your downtime. It's like all the rest of us have seen. We see our bill, and you bill them what you want to bill them, and they send you what they want you to have. And then that number again, sorry, I'm not on that slide right now, but the private pay is...
Yeah, we don't have
Okay, we don't have we don't have the private pay, but
such a variable rate. We didn't put a dollar figure on that.
but it's typically probably someplace in the neighborhood of $500 or $600.
So is that negotiated, or is it you all just accept what they give you?
It's not very negotiated.
Yeah, the latter.
They would say it's
Believe me, I
negotiated, but it's not
understand.
very negotiated.
I understand. Thank you.
Yes, sir.
You mentioned House Bill 484, which is a great vehicle to help
Yes, sir.
provide the educational opportunities for EMTs and paramedics you mentioned, but you also mentioned there was an appropriation along with this. I understand there was a fiscal note that said $100,000 for administrative expense of the fund itself, but again, no appropriation at this last budget for 484.
Yes, sir. That's correct. That is correct. And looking at other states, when we were helping to create 484, obviously we looked at novel and outside the box ideas, but we also looked at other states as well and what they were doing and how they were being successful. They had initiatives that were similar to 484. Of course, we catered that to what we needed in the state of Kentucky. There were no appropriations. Other states, just for an example, Michigan has a similar initiative to totaling grants of $8 million, Texas $21 million, Missouri 6.3, West Virginia 10, Pennsylvania 3. I mean, and we can go into the details of what we based ours on the minimum we thought we would need to make a difference, because too little and we're just wasting money, and too much we're not being good stewards. So we thought it's $6 million over 2 years, so $3 million a year we think would be a shot in the arm that would get us off the ground. And then if we can fix reimbursement and we can get a little bit more blood from the proverbial turnip, we can keep that going ourselves. That's our goal. We don't want to be propped up forever. We just need a little shot in the arm to get us off the ground.
I appreciate that sentiment, because obviously everybody has challenges financially and a lot of requests for monies, but this certainly is reasonable. But this is going to be a central theme in this committee meeting today, is we pass laws, but then we don't have appropriations to support the laws that we pass. But excellent presentation. I appreciate you being here this morning. And any committee members, if you have any other questions, feel free to reach out to these gentlemen. I'm sure they will be available to you. So thank you, gentlemen.
Yeah, please do reach out if you need us, and thank you for your time.
Thank you. Next presentation is updating on Kentucky Statewide Trauma Network.
Thank you, Mr. Chairman. My name is Richard Bartlett. I am serving as the Kentucky Trauma Program Director, as provided for under the Trauma System law that was passed by you folks in 2008. Trauma, as the law says, is a severe health problem. It's a major cause of death and long-term disability, but unfortunately our law was passed in 2008 without any funding. So we have built a system essentially using voluntary assistance, grants, and gifts, and we've grown it from 4 verified trauma centers in 2008 to where we are today, which is about 23. And I've got probably 5 to 7 more that are working hard to become trauma centers down the road. And it's clear the trauma centers save lives and money, because it means the difference between full recovery or serious disability down the road. If we're going to grow the program beyond what the law envisioned in 2008, it's particularly in rural areas, as you just heard, there's a great need in rural areas. It's time for some investment. I think it's significant that we came on this agenda right after the Kentucky Board of EMS. I spent 20 years of my life before I came to Kentucky Hospital Association, where we're currently based, running EMS programs in 2 different states. And it's clear that the trauma system starts at the patient's side, whether it's in a ditch, the side of an overturned car, or whatever. It starts with the trained, skilled hands of EMTs and paramedics. And then it's followed up by that crew transporting them to an appropriate facility, closest appropriate facility, hopefully a trauma center. But in large swaths of our state, we don't have those yet. We need to develop some of those. And in worst case situations, it may involve a secondary transfer to a higher level of trauma care, a level 1, level 2 facility somewhere else in the state. And unfortunately, we're running into problems, as you just heard from our EMS partners. The services are struggling, and I've actually had ambulance services that have refuse to transport unless there's insurance or some coverage or somebody's willing to front the bill, which means we've got sometimes delays that have gone 5+ hours or more to move a critical patient, or we have to throw them onto a helicopter at extremely high costs in order to move that patient to some of these other trauma centers. I'm going to pass the presentation time that we have left now to 3 of my physician colleagues who are involved with us. First will be Dr. Andrew Bernard. Dr. Bernard is the Trauma Program Medical Director at the University of Kentucky Healthcare, which runs a Level 1 adult, a Level 1 pediatric center, and is developing Level 4 centers in 2 other hospitals in their system. The second presenter will be Dr. Jason Smith, who is the Chief Medical Officer for the University of Louisville Healthcare System. University of Louisville runs an adult Level 1 trauma center in Louisville. And the third will be Dr. Richard Kales. Dr. Kales has a long history in emergency medicine, working in EDs and trauma centers across the country. He developed one of the first trauma registries and has actually written a textbook on what it takes to be a trauma system. He is currently serving as the chair of our Trauma Advisory Committee. So I'll turn it over to Dr. Bernard.
Thanks, Dick. Good morning. I'd like to begin with a story. June 5th, 2006, 16-year-old Andrea LaFan from Dykesburg near Paducah was on Kentucky 295 near her home. Someone crossed the center line and struck her car. The two people in the other vehicle died instantly as their vehicle burst into flames, but Andrea was alive. She was extricated from the vehicle, and though she was 25 minutes from Paducah, she was flown 80 minutes to Evansville, where on short final approach to the heliport at the trauma center, she died, and she couldn't be resuscitated. Andrea LaFan had survivable injuries, and with proper trauma care, Andrea LaFan would be 34 today. Why was she not taken to Western Baptist, an excellent hospital where they do surgery, complex care every day? The answer is because there was no plan to care for injured patients at Western Baptist in 2006, and there still is not an organized plan to take care of injured patients at Western Baptist in 2024. Andrea's death was preventable with an organized, funded trauma system. What's more, in Kentucky, there's an Andrea LaFan, somebody who dies from preventable injuries almost every day. There has been since 2006. And those people who have died are people just like you. They are spouses and parents, their children and grandchildren, and their friends. How can this be, you ask? It's really no surprise, because injury is the most common killer of young Americans and young Kentuckians. It's also the most costly disease because injury affects disproportionately a younger population of citizens, people who are in the workforce. Injury costs Kentucky more than cardiovascular disease, stroke, and cancer combined. Not healthcare costs, but in cost to society. 5,000 people die from injury in Kentucky every year, and by conservative estimates, an organized funded trauma system would save 5 to 10% of those individuals. That's 250 to 500 lives every year. But an investment of about $1 million is needed to make that change. What would $1 million do, you ask? We have good hospitals, but they need education and organization of their trauma care. In the current state, there are vast deserts that you drive through to get to this committee meeting, where if you're injured, you are far more likely to die than if you're injured right here in Frankfort, Franklin County, where there is an organized, established Level 3 trauma center. We have EMS, albeit under-resourced and underfunded, but we have some EMS. They need education. They need organization. They need trauma training, triage training. They need to know who to take where, and they need to be updated when new centers come online with your investment. Then how will you, Kentucky's leaders, know that the system's working? We need data, completely and accurately entered into a trauma database that allows system improvement and performance improvement. When we underperform, and sometimes the system will underperform, this database will allow the analyst who monitors it to help us make system improvements. For example, Senator Meredith, you could ask for a report of traffic deaths in Grayson County for a year compared to your surrounding peers in neighboring counties, and an analysis of those opportunities for improvement that have been identified that might have saved people's lives, and what the trauma system leadership is going to do to reduce death rates in your county the following year. You could ask for that with an organized trauma system. And finally, the trauma system needs leadership. At my center, I and our trauma program manager are responsible for all trauma center operations. We need a trauma program manager for Kentucky who can educate and organize trauma centers using trauma data to guide system improvements. Imagine being taken to an emergency department in Kentucky where the staff have no formal trauma training, no formal trauma plan, no protocols, no full-time trauma team leader, and no record of what takes place in your trauma care. Welcome to trauma care in Kentucky's hospitals. Welcome to the Kentucky trauma system. I'm going to finish with one brief story. I won't use his name because unlike Andrea, he's still alive and I don't have his permission to use his name. I'll call him Steve. Steve was injured near Danville and taken to Ephraim McDowell, where they have a Level 3 trauma center. They have a trauma response plan, they have a trauma team, they have data collection, they have a trauma team leader all the time. Steve was taken to Ephraim after a crash, initially supported with blood transfusion, and because they train every day to take care of trauma victims, they quickly recognized his injuries were complex. Fortunately, they have a plan to transfer rapidly when injuries exceed their capabilities, and they arranged transport to UK. The plan even included how he would be transported. Before he arrived at UK, we had seen his x-rays because part of the plan was pushing his x-rays to us electronically. So we knew what he needed. Almost immediately upon arrival, he was anesthetized, underwent surgery. His heart had been almost completely torn from its blood vessel attachments, but he survived. He survived because the system worked. He's lucky he was where he was when he was hurt. Good trauma care and surviving injury is not an accident. We should have success stories like this every day in Kentucky, and if you fund this system, we will. Jason?
Thank you, Andrew. So I think it's probably a bit passé these days to say that we're at a crossroads, ladies and gentlemen, but we are truly at a crossroads here within the state of Kentucky and the Commonwealth. You know, we're at an intersection that talks about our past decisions, our present realities of healthcare and healthcare shortages here within the Commonwealth, and also what we want to do as a future for caring for Kentuckians who are injured. We know that trauma is a leading cause of death for those between the ages of 1 and 44 in Kentucky. It's a leading cause of death between the ages of 1 and 44 in the nation. We also know that if you look at data from the CDC between 2016 and 2020, that Kentucky has an outsized rate of death for preventable injuries compared to the national average. That's a simple reflection of the trauma system that we have or do not have in place within our Commonwealth today. The other simple fact of that matter is that our state often struggles with a low health rate within our state itself and a low life expectancy. And on top of that, you put a trauma system that takes the best and the brightest and some of the most productive and important years of their life out of our Commonwealth because we can't provide the care that we need. We know that statewide trauma systems pay financial dividends to both the state as well as to the community surrounding them. Just a few years ago, our colleagues in Arkansas took their own state, which mimics ours in many ways regarding the rural nature of the state and the cities that it supports. According to that study, the analysis of their trauma system looked at a 5-year, $20 million investment and identified that there was $187 million returned in saved lives and productivity simply because they identified patients within that system that they had preventable injuries and were able to save because, as my colleague presented, the trauma system worked. They're in the right place, the right patient, at the right time, and they were able to save those lives and keep those patients. But the realities of 2023 are more than just we need the system. We are spending a little over $3 million a month right now in Kentucky, sending Medicaid money out of our state to supply trauma care for individuals to out-of-state networks. And that is only increasing and has only increased over the past 2 years since the pandemic, as we've lost more and more of our rural health care providers and more areas that are being able to care for injured trauma patients around the Commonwealth. We know that it is a tall order to ask a hospital to stand up and be a trauma center, be that a level 3, a level 4, or a level 1 or 2. We know that there are expenses associated with that. There's difficulties in managing data. There's staffing shortages. We know those exist, but right now we have no way of being able to provide the funds or help to the communities that need this most. We also know that there are 42 counties right now that are underserved by hospitals, period. In our 120 counties in Kentucky, there are around 42 that do not have a hospital, which means our EMS providers are sometimes, as you heard, traveling hours, leaving 2 counties unserved by EMS as they transport patients to the closest facility. And when they arrive at the closest facility, there are no protocols or procedures in place oftentimes to get them and move them to the most appropriate level of care. And I said we are at a crossroads, but we have a strong backbone. We have a foundation. UK, U of L, Pikeville, Norton Children's are some of the most highly trained individuals across this country in providing trauma care. We should be proud of them. They do things every single day that save lives. We spend many sleepless hours in these operating rooms in the hospital in order to make those lives matter and make those hours and time matter. We don't need more UK and U of L. We've got plenty. What we need are more Owensboroughs. We need more Markham and Wallaces. We need more Harlan ARHs. Those are our level 3 and our level 4 centers that can provide care in our communities. They can keep Kentuckians within our own counties. They can keep Kentuckians within our state. They can keep our Medicaid dollars within our state. And they can provide and save the lives of the Kentuckians that present to their hospitals. So ladies and gentlemen, we are at a crossroads, and the unfunded mandate of a trauma system in today's day and age with the realities facing the critical access hospitals and the rural healthcare that we have is simply an untenable situation that will not improve. And it is costing the lives of Kentuckians every single day. Dr. Kales?
I'd like to thank the committee for hearing us today. My name is Rick Kales. I'm an emergency physician. I have lived in Louisville for the last 25 years, but I've never worked there. I've worked solely in the rural hospitals. I would ask that each of you have a color handout. This summarizes everything I'm saying on one sheet. I'm also going to save you the drama and tell you what I want you to remember before I start. The first thing is that this is a rural Kentucky problem. We are not here to help Louisville, Lexington, and Frankfort. That's not where I worked, and that's not where I think the problem is. The second thing is that the system is the solution. And if you look in the top of that, there's a graphic that actually explains the entire trauma system in one graphic. It's a matter of getting the right patient to the right hospital at the right time. And there are 4 pieces to that: prevention, EMS, the trauma center, and rehab. Everything is in that one graphic. If that's all you take home today, we've had a successful conversation. Now, having said that, when I got out of medical school, which was 50 years ago, my best friend was an Army Ranger paramedic from Vietnam. And he guided me, not even knowing it, into trauma care as a system. When you think of trauma, I want you to think of MASH. What it is a MASH response. And that is a system response. It's that simple. Now, we don't do it like MASH, but it's the same problem and it's the same solution. I spent the first half of my life in California working in the biggest trauma centers in the country. I trained at Los Angeles County. I ran the ER at San Francisco General. And those are well-oiled team efforts. It's like the Super Bowl. They make no mistakes. When I moved here, I flipped the coin. And for the past 25 years, we have 29 critical access hospitals in Kentucky. I've worked in half of them. And that was my entire career in this state. The way I got started in that was back 30 years ago in the early 90s, I got in the car with one of the folks from the Kentucky Injury Prevention Center, Dr. Spurlock, and we visited multiple centers. We went to Pikeville, Prestonburg, Paintsville, Hazard, Harlan, Paducah, Murray. These were all places that had very limited capability then. This was in the 90s. And we were preaching systems. I also worked nationwide with 26 of the 50 states to set up the kinds of systems that we're talking about today. But I mean the team response. I'm not talking about the skills that my colleagues have here in the operating room. I'm talking about getting the right patient to the right place at the right time. The last thing I'll give you as an example is that out of the places I worked, and this is very ironic, only one of them actually was a level 4 trauma center at the time. One other, I have a before and after. I won't name the facility, although I am going to compliment them. And when I had worked there in 2012, I could call it controlled chaos when a patient came in with a major injury. When I went back 5 years later in the same capacity, it had become a well-oiled machine. Because what had happened is that the volunteer team that these other gentlemen have spoken about was able to get this moving. The problem is we are overextended and we need to grow, and we're having trouble with that. So I would bring you back to the 3 things I told you up front. Number 1, this is a rural problem in Kentucky. We are not talking about places that are already up and running and doing well. The second issue is the system is the solution. I think it's excellent today that we had EMS come on before us, because that is a major part of the problem, and I agree with 110% of what they said. The last item is that what we need to do is to expand what we already have, and we don't have the resources to do that. I'm going to give you a shocking statistic that I want you to take home with you. There are 2 million people in this state that are covered by this non-system. We're asking, or ask, because one of you asked EMS what their ask is. The ask is $1 million. for 50 cents a person a year, we can fix this, and we'd like your help. Thank you.
Thank you, gentlemen. Excellent presentation. We have about 5 minutes left. Have 3 in the queue for questions. Senator Frankie Frohmeyer, you're first.
Thank you. I feel so ignorant about this, but I'm about 575 days as a state legislator, so just trying to put this puzzle together. But I think about the best of collaborators, and I've had a lot of experience with and against the Kentucky Hospital Association. And I think about who's in a position to collaborate, because I believe all the hospitals pay a fee to be a member of the Hospital Association. Rather than create an additional bureaucracy, is there a way that perhaps the systems that are in place could better collaborate to help create this trauma network with knowledge of the rural as well as the urban and all in between?
I'm going to give that to the CMO at the table.
Let me take. So that's exactly what we've been doing for the last 16 years. You know, I think 2006, 2007 is when we started the KTAC here in Kentucky and started looking at developing a trauma system really out of nothing. And Dr. David Richardson, Dr. Mary Fallett were here at that time speaking about this very problem. And we've gone forward with an unfunded volunteer mandate for many of the things, and KHA has been a sponsor and help in all of those. It's time to take the next step. And the next step is a well-funded and developed system within our state to be able to take that into other areas which have been unable to be reached that we currently have with our volunteer status that we have.
And does the exorbitant expense that the state contributes to the Medicaid and all of the system about the folks that you mentioned are receiving tremendous tax dollars towards their health needs and proactive or reactive health, are those dollars not available to be applied towards this coordinated effort?
So the dollars going into the healthcare system and the hospitals from the Medicaid patient standpoint are typically going to cover the hospital costs. We know that trauma care costs a lot. And I'll take University of Louisville as an example since it's my own institution. When I'm on as a trauma surgeon on a Friday or a Saturday night, we often have 15 to 16 people working to save the life of one person. We may use 80 units of blood. We may be in the operating room for 3 to 4 hours using x-ray, what have you. They may have a 3 to 4 week hospital stay. They may have a 3-month rehab stay. And it's not uncommon to see those. And that's what the Medicaid dollars are helping to support. The problem is that the rural healthcare and the level 3 and level 4 centers, the smaller systems, don't have any of those opportunities to be able to make and afford to be able to run and fund a system at the level that we have at University of Louisville, University of Kentucky. We see a large volume of patients, and the volume helps us make the margin on those patients in the healthcare system. They don't have that. They basically see them, they treat them, they send them somewhere else. They get no dollars. There's nothing for them for that. And the amount of money provided to the healthcare systems at that time for the development of this system in the smaller rural critical access hospitals simply doesn't exist.
But establishing a small hospital as a level 4 trauma center, that's the lowest level. That means you have an organized plan, somebody on staff, and you can get a CAT scan, and you have a unit of blood available. They are able to bill for their trauma team activation, even if they send the patient out right away. And those trauma team activation fees can be good for that small rural hospital. It can help them pay the staff. And as the trauma care, the systems of care, how we work as a team gets better, all the boats rise. The cardiac care gets better, the stroke care gets better, the quality sort of diffuses out through the whole hospital. That can be a significant secondary impact. But somebody needs to go down to that little rural hospital and say, I know you have a lot going, Rick, but I really think you need to be a level 4. And he says, how do I do that? It just seems so big. And I say, we're going to get you through it. And I'm the trauma program manager for the state. That's my role. And I go hospital to hospital, and I do that, and I help. That's what we need.
I'd like to take that one step farther because I don't think we answered your question. The hospital I use as an example had almost no financial outlay. They were using existing people, but they were training them as a team. What the ask for is for the state public health department, where the legislature actually put this in 2008, to have enough funding for the oversight for the state program. And the expansion, as I said, is focused on the rural health. So this is really a program expansion with what we call technical expertise. and supervision. I hope that helps.
Thank you for that question, Senator Funky Fromeyer. Again, we're running short on time. We have 3 people in the queue, Senator Berg, Senator Douglas, and Representative Camille. So please be concise. Senator Berg.
Thank you, Mr. Chairman, and thank you, gentlemen. This is a presentation that is extraordinarily near and dear to my heart. I don't know if people in the room know, but my father was a trauma surgeon, trained at University of Louisville. And I actually started the Department of Emergency Radiology at University of Louisville over many, many years ago. This is, I just want to try to explain that trauma is now the #1 killer of children in the United States. And we can actually, with a machine that works, save some of these people. They do not have to die. And $1 million to get what has already established in the state, because years and years and years ago, people cared enough to try to get a trauma registry, to try to do the work that's needed. And now, guys, what we have to do is take it to a level where it will work. It will work for every rural hospital in this state. You know, I went to a meeting not too long ago where Mary Fallett was talking. And Mary Fallett, for those of you who don't know, is a female pediatric surgeon. That's a rare breed. And she is literally talking about using this trauma network to be able to talk rural surgeons through emergency surgeries at their facilities, because there is not a dedicated surgeon that does pediatric trauma at their location. I mean, these are the type of things, if this is your child, if this is your family member, if this is you want this in your state. Thank you.
Thank you. Representative Camille.
Thank you, Mr. Chair. Thank you all for your presentation. I've got a question about reimbursement rates, but looking at motor vehicle accidents, it seems like that may be where some of our greatest trauma may come from. I'm not an expert here, just a thought. But given that auto insurance and the PIP benefit is a billed rate and not a negotiated rate or charges, why doesn't the PIP benefit cover some of these costs? Have you all looked into that, or?
It's an excellent question, and I think one of the things you talked about is the PIP benefit goes to pay for all kinds of different things across the system, and once you nibble away all of those little things, there's not much left for anything else. And so one of the things we talk about is trying to figure out perpetuity funding for a system like this is looking at all avenues for that, be that from an insurance perspective or other things. I think that's the question we come and the ask we come to all of you is help us find a way to fund a system in perpetuity that we can continue to work and manage and develop these hospital systems.
Thank you.
Sure.
Gentlemen, excellent presentation. Great information. Look forward to working with you in the future. Thank you.
Thank you.
Going to have a slight change in the agenda. If I could, I'd like to hear agenda item 6 first. Is the Kentucky Rural Hospital Revolving Loan Fund. If representatives from the Cabinet of Economic Development are here, I ask you to come forward. Okay, so much for that plan. We'll go back to the original agenda, 340B drug pricing program. know you're frequent presenters here, but if you would, please identify yourself for the record and feel free to proceed.
Good morning. I'm Jim Musser. I'm the Senior Vice President for Policy and Government Relations at the Kentucky Hospital Association.
Good morning. I'm Nancy Galvani. I'm the President of Kentucky Hospital Association.
And good morning. I'm Wes Butler. I'm an attorney in private practice in healthcare matters and represent the Hospital Association as well as Kentucky Hospitals and Health Systems.
Thank you. Please proceed.
All right. Well, good morning, Chairman Meredith and members of the committee, and I want to thank you very much for having us here today to talk about the 340B drug discount program, which is very important to our hospitals. This is a critical program for the health of our patients and for access to care in rural areas. So there's been a great deal of misinformation floating through these halls about the 340B program, and so it's very important for members of the General Assembly to know the facts about this program and how the program benefits your constituents and our patients throughout the state. The program allows 73 Kentucky Safety Net hospitals to purchase outpatient prescription medications at the same price the pharmaceutical companies offer to their best customers. Frequently, that is a government purchaser. Again, the medications are not given to the hospitals. They're sold at a discount, which is determined by the pharmaceutical company from its dealings with its largest customers. And a very important point, there are no taxpayer dollars used to fund the program beyond the cost of oversight of the program by the Federal Health Resources and Services Administration. Hospitals use the savings from the discounted pharmaceuticals to fund services for our patients. As you can see from this slide that's provided by the Congressional Budget Office, the vast majority of the savings goes to oncology services, making cancer treatment more readily available closer to the patient's home. One of the great benefits of the program is that each hospital is able to use the savings from the program in a manner that's consistent with the law, but also best serves their local community. For example, some small hospitals in rural areas use the 340B savings to keep the lights on and the doors open to ensure access to care for the community. But for the 340B program, Breckenridge Hospital would have been forced to close its doors, and the community would have lost access to care. Some hospitals use savings from the program to provide discounted or free medication. For example, the University of Kentucky uses savings from the 340B program to pay down extremely expensive copays for medications so that rather than facing a $40,000 a month copay for the critical immunosuppressive drug Stelara, savings from the 340B program are used to reduce the patient's cost to $50 a month. $40,000 versus $50. St. Clair Hospital in Moorhead uses savings from their 340B program to cover the cost of a hepatitis C clinic to help make treatment timely to Hep C patients. While treating Hep C is expensive, leaving it untreated and allowing it to spread, often without the knowledge of the infected person, becomes an enormous cost for the state. In healthcare, we must often ask, what's the cost of leaving disease untreated? In the case of Hep C, it's near epidemic proportions in Kentucky, and left untreated, it's likely to cost the state Medicaid program millions upon millions of dollars if people are left untreated. So the use of 340B savings to ensure treatment of Hep C is a benefit to the patient, to the public, and the public purse. The drug companies complain that spending on the program has risen dramatically over the years, and that is true. What they have not explained is that the law was changed to expand the program. The expansion was done with the agreement of the pharmaceutical industry in order to have a place at the table for the creation of the Affordable Care Act by the Obama administration. In 2010, Congress expanded the program so that more rural hospitals could participate. Critical access hospitals, rural referral centers, and rural Soul Community hospitals were made eligible. And that was a tremendous benefit for rural states like Kentucky. Since that time, there's also been a significant shift in the delivery of health care, and where services that used to be provided only on the inpatient basis can now safely be provided in the outpatient setting. Since the 340B program only applies to outpatient medication, the shift to outpatient care logically has made more medications available for the discounts. Medical advancements are also contributing to growth in the 340B program. As you can see from the slides, the vast majority of 340B savings are used to pay for cancer and immunosuppressive medications. These and other advanced medications are improving patient survival rates, but they come with enormous prices, and they explain a large part of the increasing cost of the program. Kentucky has some of the highest cancer rates in the nation, so it's a tremendous benefit for patients to receive treatment locally. But the cancer drugs are so expensive that many hospitals would not be able to continue supporting cancer programs if it were not for their 340B savings. The 340B program was also expanded by the federal government in 2010 to cover so-called contract pharmacies to provide patients more options for obtaining their medications. Most rural hospitals lack in-house pharmacies, and they contract with local pharmacies to provide medications covered by the 340B program. The problem we face is the large pharmaceutical manufacturers have refused to deliver the medications covered by the 340B program to our contract pharmacies. That refusal by these large, highly profitable multinational corporations to deliver medications to the contract pharmacies creates massive losses for the critical programs our patients need. Without the savings from the 340B program, critical health services will become unaffordable, and hospitals simply won't be able to provide the care that is funded from the 340B savings. We urge the General Assembly to act, as many other states are doing, to ensure the delivery of 340B medications to local hospitals and pharmacies in Kentucky. Kentucky will not be an outlier in enacting legislation to require delivery of these medications, because at least 19 other states are actively working on similar legislation. 6 states, including Arkansas, Mississippi, Louisiana, Missouri, Maryland, and West Virginia, have already enacted such legislation. Our patients and your constituents should not be treated differently than patients in other states. So please help us to serve our patients by enacting legislation to ensure delivery of the critical medications. To help explain the program further, I'll now turn to my colleague, Wes Butler, to explain the federal law that created the 340B program, how it's evolved over the years, and he's also going to describe how Senate Bill 27 from the 2024 regular session would affect the program if it's enacted in the next session of the General Assembly. Wes?
Well, good morning again. Good morning again, Chairman Meredith and committee members. As I've been introduced before, I'm Wes Butler. I'm an attorney in private practice based in Lexington. I have the privilege of representing the Kentucky Hospital Association and many of Kentucky's hospitals and health systems. A substantial part of my practice involves advising hospitals, not only in Kentucky but also in other states, regarding compliance with the 340B program. My appearance today is primarily to provide a bit of background on the 340B program, context through some more recent events in it, but then finally also to address any questions that you have. We recognize the policy function that you have, and it's important that you make decisions based upon a full understanding of this federal program, and it's admittedly complex, but hopefully today with some of the points that we'll raise, we'll bring it back into context. The 340B program was enacted in 1992, but to understand the 340B program, you actually have to go back to 1990. Congress enacted the Medicaid prescription drug rebate program. Since state Medicaid agencies are one of the largest purchasers of prescription drugs, Congress created the Medicaid drug rebate program to require drug manufacturers to give rebates to state Medicaid programs. The goal of that Medicaid rebate was to alleviate the cost of prescription drugs on state legislatures. However, the Medicaid drug rebate program had unintended consequences. While state Medicaid agencies paid less for prescription drugs, hospitals began paying more for those same drugs. Drug manufacturers simply shifted the cost of the Medicaid rebate to other drug buyers by increasing the cost of their prescription drug purchases. Hospitals took the brunt of this market shift, and hospital drug costs skyrocketed to unsustainable levels. To fix this market shift, Congress passed the 340B program in 1992. The program required drug manufacturers to offer upfront discounts on outpatient prescription drugs purchased by safety net providers, including nonprofit hospitals. The federal 340B program has now been in place for 32 years with very little change in Congress apart from the change that Nancy mentioned back in 2010. It's important to remember that hospitals have to purchase the prescription drugs they use for patients. Prescription drugs costs represent one of the largest costs for hospitals. The 340B discount, the availability for that price reduction, save hospitals millions of dollars each year on their drug purchases. Without the discount, Kentuckians and Kentucky hospitals would bear a much higher proportion of the cost of prescription drugs. Drugs purchased with a 340B discount are dispensed to Kentuckians through hospital pharmacies and also contract pharmacies, including small independent pharmacies as well as chain pharmacies like Kroger's. These contract pharmacies allow hospitals to provide greater access to prescription drugs so that Kentuckians do not always have to visit a hospital campus to fill their prescription. For a rural state like Kentucky, access to prescription drugs is both a challenge and a responsibility. Unfortunately, over the last few years, several drug manufacturers have restricted access to the 340B discount for Kentucky hospitals that use contract pharmacies. The result of this restriction means higher prescription drug costs for Kentucky hospitals and ultimately less access to prescription drugs for Kentuckians. In response to the drug manufacturers, many states responded forcefully to these drug manufacturer restrictions. In 2021, Arkansas was one of the first to pass a law that prohibits drug manufacturers from denying a 340B discount to an Arkansas-based hospital and contract pharmacy. Drug manufacturers challenged that Arkansas law, but earlier this year, the federal Eighth Circuit Court of Appeals upheld Arkansas's law. As Ms. Galvani mentioned, many other states followed Arkansas's lead with legislation to protect the 340B discount for their state. Louisiana, Mississippi, West Virginia, Missouri, but you can also add Idaho, Nebraska, and Oklahoma to that mix. With this background, I want to close my testimony on a more practical point. The legislative action in other states necessarily impacts Kentucky's market for prescription drugs, and the lesson we learned in 1990 is relevant today. If states like Arkansas, Louisiana, Mississippi, and West Virginia require drug manufacturers to give 340B discount in their states, where will the drug manufacturers shift the cost of those discounts? The answer is obvious. Higher drug costs will be shifted to states like Kentucky, who do not have similar laws. This is the reality for Kentucky healthcare providers, not a theory. Senate Bill 27 from last session sought to prevent this cost shift from adversely impacting Kentucky. The language of Senate Bill 27 was very simple. If a drug manufacturer offers a discount in another state, that same discount must be offered in Kentucky. The premise of the law was straightforward. A drug manufacturer cannot discriminate against Kentucky healthcare providers by charging Kentucky providers more than what they charge providers in other states. Put more directly, if a drug manufacturer offers a discount in West Virginia, then the discount should be offered in Kentucky. As one of your colleagues mentioned in a prior testimony, it's very akin to a most favored nation type status for Kentucky healthcare providers. Kentucky's General Assembly will have an opportunity to level the playing field by allowing Kentucky providers access to drug discounts that are offered in other states. But it's important to note that the cost of inaction will only increase for Kentucky hospitals. Appreciate the opportunity to testify today, but I'm also here primarily to answer any questions that you might have about the 340B program if I'm able. Thank you.
Thank you. We have numerous questions, and I'm not sure we will be able to get to everyone that has an interest in this, because we will adjourn before 11 o'clock today because we have another committee meeting, but we'll try to get through as many as possible. I don't remember seeing your slide, but how much is the 340B program worth to Kentucky? I think you had a number of 120 million.
That's just the losses on the contract pharmacy, the drug manufacturer's refusal to ship the 340B drugs. We surveyed our hospitals, and last year it was 122 million, just that piece of it.
And what's specific to rural providers?
The majority was to rural, was $68 million of that amount. So the majority is actually in the rural hospitals. I think it's 45 rural hospitals. So it's hitting our rural hospitals really more so than the urban.
And without that revenue, how do they make up that shortfall?
They have no way to make it. I mean, we have critical access hospitals going to lose $1 million. They have no way to make that up.
To this end, when I asked the KJ to testify today, it was to illustrate the impact that this program has on Kentucky. To that end, with the numerous questions we have here, I just want to ask folks, let's not get into the debate about the 340B program. This is a federal program. We can't change. It's got to be federal at the federal level. What we're asking for, Senate Bill 27, which, being quite transparent about this was my bill, is to say Kentucky's going to be treated like every other state, period. So again, with that, I know Representative Whitten, you had the first question.
Thank you, Mr. Chair, and thank you all for your testimony. I just have a couple really quick questions. As I understand that there is currently federal legislation pending before Congress to reform the 340B program and to provide some transparency. What would your opinion be on this avenue versus kind of a statewide patchwork that we're seeing right now?
Yes, thank you, Representative Whitten. I've worked in 340B since about 2004, and I've seen a number of pieces of legislation in Congress come and go. But as I mentioned in my testimony, there's been very few changes to the program. It is always a topic of debate in Congress, but quite frankly, the experience from, I guess, my gray hairs of watching the 340B program go up and down within the halls of Congress has led me to believe that I really have no hope that there will be a lot of changes at the congressional level without substantial changes generally in the populace. So I really put very little stock in any of the legislation that's introduced year to year in the 340B program, because just from my experience, very little of it has actually come to fruition. The more immediate concern, of course, right now is the particular circumstance in which drug manufacturers are picking and choosing which states are going to get the discounts and which will not. And the fear that I have, of course, is we want to have the lowest drug costs prices possible in Kentucky, and part of that is by lowering the cost of the drugs themselves for purchasing. But if some states get that discount and other states don't, ultimately that just shifts the cost to those states that don't regulate it. So we're in a position in which we have to deal with the reality and addressing the market of that reality, more so than the more political and policy issues that happen within Congress. Legitimate questions, legitimate issues, I won't dismiss those, but it's just my experience. I've seen very little movement from it.
Thank you. And one more quick question, if
Make
I may.
it quick, please.
Yes. When you mentioned the contract pharmacies or the PBMs, these discounts, are they required to pass those discounts on to their patients in any way?
Well, from a PBM standpoint, it's a bit separate from the 340B program. As you know, hospitals have very little say as far as what PBMs do and don't. When we're talking about contract pharmacies, what we're really talking about is attempting to provide access to drugs for the Kentuckians that are going to be getting them. As often as possible, for a lot of the drugs, they'll happen at the retail pharmacy, in the independent pharmacies, or the Krogers and the others that are available for the patients right there. But there are subsets of drugs that are available only through particular pharmacy resources where PBMs and others will have some impact in that. Those are issues that I think Senator Wise has been a leader on with respect to Senate Bill 50 and others with PBMs in the past, but they really don't have as great of an impact, at least from the hospital perspective, with respect to the 340B program. We just can't impact it. We deal with what is there.
Thank you.
Thank you. Representative Fraser Gordon.
Thank you, Chair. I have two very brief questions, clarifications actually. In regards to the contract pharmacies that you mentioned, are these all in-state pharmacy contracts?
No, they can't be, because not all drugs are going to be manufactured and produced for sale in state. Some of them have to be out of state, but often the drugs that are out of state are drugs that are specifically made, and there are only a handful of providers that make those available, such as certain specialty pharmacies and compound pharmacies. as much as possible, of course, the healthcare providers try to make sure that purchases for drugs occur within the state as part of a better patient catchment as to that. But they can't restrict patients from accessing pharmaceuticals out of state, and in many times that's the only access point for them.
Okay, and then the other clarification was, going back to the intent of the program, was that to help patients or help hospitals when the 340B was?
I think it was fair to say that, according to Congress's own words, it's to stretch scarce resources within the hospitals for providing it, because hospitals were the target for the program.
Okay, thank you.
Well, just one clarification on that question is hospitals are not the only beneficiary of this program. In fact, in your home community, there's a rural health clinic that relies on these funds, and they've shared with me that they use some of those funds for transportation of patients to University of Kentucky for cancer treatment. Senator Wise?
Thank you, Mr. Chairman. Thank you all for the presentation. Just kind of piggybacking off of Representative Fraser Gordon, on the number of contract pharmacies, how many of those do we have, or excuse me, how many contract pharmacies does Kentucky Hospitals use? Do we have a direct number?
Yeah, pretty much all of that information is available, publicly available through HRSA's website on OPAIS. It's their database for all contract pharmacies. Most hospitals will have some contract pharmacies. Not all hospitals have contract pharmacies, but it'll vary based upon the particular provider. But that information is available, and we can certainly provide it to you.
If we were wanting to also find out how many of those are out of state versus in rural, low-income areas of Kentucky, would we be able to find that also?
Yes, sir. All that information is publicly available, and that can be analyzed.
Okay. Last question. Do the contract pharmacies or PBMs pass these discounts on to the patients?
Well, can't really speak with respect to the PBMs. From a contracting standpoint and from a purchasing standpoint, this is a drug discount program in which the hospitals will go in and purchase drugs at a discount. Exactly how PBMs and others decide they want to pass their discounts, we can't say. But as Ms. Galvani mentioned, with respect to the discounts that the hospitals get and the savings from that, that automatically goes to a lot of the patient services that are already provided, yes.
Yeah. Nancy?
Yeah, I was just going to say, the purpose of the 340B was never to provide discounted medications for the patient. It was to help the hospitals stay open. In fact, when Congress expanded the program to add all the rural hospitals, it was in recognition that the rural hospitals were going under. And the point being, Breckenridge Memorial Hospital would have closed its doors. It was losing over $1 million a year. The only way it was able to stay open was it was able to take advantage of the 340B savings. So as we provided, the savings are to keep the doors open and to provide access to care, and that can be done in a number of ways. Some hospitals do offer low-cost medications. Others are providing a cancer program that they could never have afforded if it weren't for the discount. So each hospital is able to look at what is the best way to use that savings for their community. And so it's not all just free and discounted medication. That's part of it. And hospitals have many programs. But as I'm going across the state, what I hear most often is cancer programs are usually, way up there. And it's also these hepatitis C clinics, and it's also reducing the cost of the medicine for the uninsured and to support their charity care. So it's a number of different uses.
Thank you for your testimony.
To give a little historical perspective to this, in the early 1980s, when Medicare changed from a cost-based reimbursement formula for healthcare providers to DRGs, and put hospitals at financial risk, they learned very early on that they had gone too far. In reaction to that, they created the critical access hospital category to allow those critical access hospitals 101% cost reimbursement still, but that's been whittled away with over the years. Additionally, they recognized they need additional funding. That's when President Bush decided to start the 340B program to get those funds back to critical hospitals. Representative Raymer.
Thank you. Thank you for you all's presentation. I have just a couple questions. I'll try to keep it brief. So participants in the 340B program, are there mechanisms in place for them to report the revenue they're generating from the program and what exactly that money is being spent on? And is there a cap on the program on what the percentage that medication can be marked up?
Well, the prices themselves are solely determined by the drug manufacturers, but it's important to recognize also that Hospitals don't generate revenue from 340B. It's a cost reduction. It's a discount that comes from that. And so those two answers, I think, address the question that you have.
Well, I mean, the difference between what the cost is being passed on to the patient, since I understand that the savings aren't going directly to the patient that's the purchaser of that medication, but your savings are being used in other ways. But the difference between what the hospital purchases it at and what it's being billed at.
Yeah, again, the two variables that you're talking about, the hospital doesn't have control over either. They don't have control over the drug cost. That's ultimately up to the drug manufacturer. And in our current reimbursement system, they don't have control over the drug reimbursement either. Ultimately, with Medicare and Medicaid being the primary payer for every hospital in Kentucky, that's a set price by Medicare and Medicaid. Commercials set their price within their formularies by Medicaid. So the two variables ultimately are determined by parties that are outside of the hospital. So the ultimate goal, of course, with any hospital is you want to keep your costs as low as possible, and the drug discount program offers that availability. So it will allow different margins based upon different circumstances, but ultimately the two variables are controlled by others.
And so just like my first part of that question was, so is there a reporting mechanism in place to show then your savings from that program and then what you're spending those funds on?
I can say every hospital in Kentucky can tell their legislator how they're using their savings. They can tell this is the amount of the savings and this is how we're using the savings to benefit the community. These are all nonprofit safety net hospitals that are even eligible to participate in the first place. And every hospital in this state is able to say how they're using their savings.
I understand this is a reporting requirement from HRSA that.
Yeah, and Wes is our expert, and Jim can talk about hospitals are audited. So, to make sure that they're accounting and, only getting the savings where, they're allowed to by law, to make sure that it's only for their patients of the program. So there's extensive auditing.
Yeah, HRSA does a number of audits each year to make sure that there's compliance with the programs, and there are a number of elements that they have to meet for that, as well as consequences from it. And plus, many of the hospitals in Kentucky, and this is the area in which I work in directly, they've got good relationship with their drug manufacturers, and they will often enter into good faith discussions about the usage of the 340B discount and when it's utilized. And ultimately, I think Kentucky providers are, given my perspective from working also in other states, are some of the most compliant in the nation.
Thank you.
Final question to Senator Tishner.
Thank you so much. I'm just looking at the graph on page 3. And it's quite shocking to me to see in an 11-year time frame the growth in spending in drugs. And that's not the one. It's this one, the little bar graph. Thank you. There it is. 6.6 billion to 43.9 billion dollars in drug costs. So I'm looking at this and I'm going, okay. We always talk about unintended consequences. So in 1990, the Medicaid prescription drug rebate program, did all of a sudden that cause pharmaceutical companies to jack up their prices on products? Or with the 340B, did that lead us to start over-prescribing people? I mean, 6.6 billion to 43.9 billion in drug spending on pharmaceuticals. I mean, are we that much sicker? Are we really that much sicker in an 11-year time period that it would increase that much?
So there's a number of things at play here. Again, from going from 2010 to 2021, in 2010, they added all those different categories of hospitals. So you had more people eligible for the program. Then you had a shift. This only covers outpatient drugs. So as healthcare, as more things can be done outpatient, think of all the surgeries that can be done outpatient that, I'm shocked, hip replacements are now outpatient. So think about how medicine has changed over that time period. This discount only applies to outpatient. So as more things move to outpatient, more medications can be eligible for that discount. Cancer drugs in particular, when you think about how cancer has changed, and now when you have cancer, you go in and, the drug is almost made for your cancer. So when you look at the growth of specialty drugs in these areas, that didn't exist back in 2010, it's the evolution of the medical advancements, it's specialty drugs that are very, very costly. These medications, the discount in part is based upon how expensive the drug is. The more expensive the drug, the bigger the discount. So there's reasons for why that has gone up, but it's really been a lot of those things. More eligible hospitals, more outpatient care, and more specialty medications.
And to add to that, from what I've heard from others across the country on this, there are two particular issues, and Ms. Galvani hit on one of them. One is particularly the push, and a lot of payers started to suppress inpatient reimbursement with the intention of increasing outpatient, and a necessary corollary with outpatient is the prescription drug medication, and that's a particular change in healthcare. There's also a lot of good information out there about the correlation between the increase in drug manufacturer advertising with respect to the need and the desire and creating the market for that as well.
Thank you for the questions. Thank you for the testimony. It's been very insightful. Greatly appreciated. Our next presentation is from the Cabinet of Economic Development. If you would, folks would come forward. Folks, appreciate you being here this morning, and I ask you to please identify yourself for the record.
Thank you very much. My name is Jeff Noel, and I'm the Secretary for the Kentucky Cabinet for Economic Development.
Matthew Wingate, I'm the General Counsel for the Cabinet.
Katie Smith, I'm the Deputy Secretary at the Cabinet.
Folks, I know you've got a slide presentation here. In the interest of time, I would appreciate if we could start maybe with slide 13. Again, I appreciate all the activities the Cabinet for Economic Development is doing on behalf of Kentucky to build our economy, but again, since it's health services and specific to this issue, I'd like to talk specifically about this program, and I'm sure Senator Wise would be more than willing to talk about these other programs in his committee. So if you would, please proceed.
Absolutely. The only thing that I would do in terms of the preliminary slides is to point out that over the last year and a half, we have gone through a strategic planning process. We have focused in that effort on rural Kentucky and eastern Kentucky. And in some of the slides, you may have seen that what we have done, and it's a bit of a change management process, but we're trying to make sure that all economic developers at the local level understand, especially in rural and eastern Kentucky, that healthcare is not only a pivotal element of the economy, but also one that helps attract and grow and bringing in both providers in healthcare, people in healthcare, and companies. And so, Mr. Chairman, the only point in all of this was...
Would you say that one more time? I would appreciate that.
Hopefully it was good, but I will try not to mumble this time. We really have tried to change the dialogue about economic development through our planning process. And we've tried to use our meetings going out into the communities and using the McKinsey study to really understand that healthcare is a pivotal part of placemaking and quality of life. And whether it's in needing communities to be able to attract talent, including healthcare, it's also important to have good healthcare providing services in all communities and not just a few if we're going to see the benefits of economic development and job growth. And so what we have done is made sure that healthcare, access to healthcare, placemaking, workplace and work environments are all fundamental parts of economic development, because sometimes people get so focused on expansion and bringing in new companies, they don't understand. If you don't have great healthcare, if you don't have great communities, we can't bring in jobs. So, Mr. Chairman, I just wanted to make sure that there was an understanding. We're really making sure that the access to healthcare and the things that drive it are just fundamentally important to economic development in Kentucky. And I think that the Rural Hospital Loan Program is an excellent tool in helping to do that. Just sitting here listening and being in the other room listening, I don't need to get into the definitions of a rural hospital or those sorts of things, but you all provided us a program to look at everything from existing facilities, programs to increase or train staff. That also includes things that we bundle with our Bluegrass State Skills Corporation with a lot of hospitals for the training that they do, but also in terms of trying to attract and provide healthcare services that currently are not available. So this program can be very broad in terms of how it's used for our rural hospitals that exist out in the community. So let's go to the next slide.
If I could, just let me get the brief history. Some people may not be aware of it. This legislation was passed by Representative Danny Bentley.
Right.
And it came on the heels of Our Lady of Bellefonte Hospital closing in Greenup County, Russell, Kentucky. Cost 1,000 jobs. And at the same time, we appropriated $35 million to University of Louisville to buy a Jewish hospital. And we saw a real disparity in the efforts to try to save both the urban hospital and save a rural hospital. So this is how this program came about. Thank you.
No, and I think that history is really important because this is, like I say, an important program, and I think it can be used for a broad array of services. So let's go to the next slide. This is just the process, and it's a pretty easy process in terms of we work with communities, we work with those that are putting together the applications. Ultimately, they wind up going through our board for final approval, and then we've got a program in which those funds are dispersed quickly, and then we have a monitoring inside of our cabinet to continue to work with those organizations that take advantage of the loan program. These are the actual projects that have been approved. There are 8 of them. There's another in the pipeline that we are working on, and we can go through them if you would like. You'll notice, at least I did, that they all hover around the maximum amount allowable for up to $1 million. But again, there's kind of a broad array from working capital to the building improvements to medical equipment. What I'd like to see, and a thing that we are working on thanks to what this legislature has done, is helping to educate and build capacity in communities around additional federal grants that can be used for health care. And as you all know, you all provided a program in which the local match requirement for a federal grant could then be deemed eligible from the $200 million pool of funding. And we're trying to get out and talk to communities about understanding it's not just about water and sewer. There are programs that can be done to help support things like healthcare delivery programs and others, or even quality of life issues. And we've got a local match program, so the burden is not undue on that local community or hospital or not-for-profit that's making application. And the only reason I bring that up is because I think everything's got to be integrated in a holistic way. And my hope is we can actually get some ways in which communities and hospitals will combine going after federal grants, getting the local match, as well as applying for funding under the Rural Hospital Program for medical equipment, services, you name it. There could even be, in my humble opinion, combination of workforce training, attraction, some of the fundamental things that could be done around healthcare, combining those programs together. And that's something we're working on by trying to get our economic developers to also be proponents of use of the Rural Hospital Loan Program. This is just a map of where they are from a funding perspective, and I'll be the first to tell you that with the 8 approved and 1 in the pipeline, I'd like to be back here a year from now that we've actually made healthcare part of our strategy and the conversations we're doing with local economic developers, and we'd love to see, quite candidly, all of the funds having been authorized and in the pipeline to be used. And so we've made that part of our strategic program of work. And in fact, we'll be at meeting next week with the local government conference talking about how the local match program for the grant program and programs like the rural loan program need to be utilized. And if you're not in healthcare, if you're a community leader or an economic development leader, understand these programs and work with your local healthcare providers, find what's needed, and let's all work together to make sure we can provide those funds. Grand total of what is available, and again, let's set goals and see if we can try to get most of that money committed over the course of the next year, which we are certainly happy and willing to do. But I'm also hopeful that we can combine it again with the local grant program that you all provided, because if we can leverage that local grant program by a factor of 7 to 1, and then combine it with the rural loan program, we can see, I think, some exponential benefits both in the communities and to the hospitals in which we serve. I just close out, I made some reference to our local economic developers. You know, we don't have a really big staff, and so fundamentally what we're trying to do is use local economic developers as our channel for communicating, getting out the word about our programs, and understanding that placemaking, quality of life, workforce development, infrastructure, all those things are critical because if you help improve local communities, if you help improve the delivery of health care, the better chance we've got of growing good long-term jobs that all of our residents need. These are interdependent issues, and as an economic development cabinet, we need to step up and be more involved in those issues and get our local economic developers to be part of our overall holistic approach to serving communities and working on economic development. So, Mr. Chairman, that's a brief presentation, but obviously happy to take questions. And most importantly, we appreciate you inviting us today because these are the ways in which we can get the word out about the programs that you all have provided to us, the need to fully utilize them, and the importance of making sure that all communities know these programs are available to them.
Well, thank you. For me personally, it's very refreshing to hear the cabinet talk about rural Kentucky, and particularly the importance of healthcare in rural Kentucky. You know, I've professed for some years that people don't understand unless you live in rural Kentucky that many times our hospitals, that's their Toyota or their Blue Oval, a largest economic driver in their counties. And if we don't have that, then we've got nothing to build upon. So I appreciate that. Appreciate the report. Yeah, I would like to invite you folks back in for future sessions because we need to follow this. But this is a revolving loan fund. President's capped it at $20 million. What happens after we cap out at $20 million?
Better to have that issue to discuss, especially if we can track it back to how it's fit into a holistic program. And again, I'm just giving you an observation after now having been here 2 years on the job. The other beautiful thing about rural health care, if you go out into the rural communities, which I really have done, you find that it's the members of the hospital board, even the practitioners. They're the ones that are very active in community leadership. They're on boards, they're participating. And once you get that kind of real active community participation, a community creates a vision for itself. When you have a vision and people working together, that's what companies are looking for when they're deciding where to invest. It is all truly interdependent. And I really believe that healthcare is a major anchor, and that's why it's called out so clearly in our blueprint plan, that healthcare is a key economic driver, especially in rural and eastern portions of Kentucky.
And that's one of the reasons I wanted to move up their presentation in our agenda, because of struggle for dollars to support rural healthcare. We heard from the trauma system that they want $1 million. Really, that's not that much money, but the return is just phenomenal. The EMTs are asking for $3 million, $6 million over biannual. Again, the return on investment could be incredible. And you folks heard me say many times before, we never take time to measure the cost of doing nothing. And if we did, I think we'd find it staggering. The reason I put these three things together is there is a funding source that has not advanced that I'd like you folks to consider. And this was legislation I filed last year called the Super Speeder Bill. And this is modeled after what happens in Georgia. They had the same situation, did not have a trauma network, and needed some way to fund it. So in Georgia, if you go 20 miles over the speed limit, you get an additional $200 fine, which is put into a trauma fund. And for Georgia, this generates $20 million a year. The legislation that I filed had a compromise on it that would actually call for 25 miles over the speed limit. And think about that. You're on the interstate, 25 miles over the speed limit, you're going 95 miles an hour. Secondary roads, you're going 80 miles an hour. I don't think it's unreasonable to fine people those kind of dollars, particularly when it was noted that primary cause of trauma in rural Kentucky are car crashes, usually speeding. And for Kentucky, if we went with 20 miles over the speed limit, that would generate $10 million a year. But I was asked to increase it. I'm really not sure the logic behind it, but I agreed to do it in the interest of trying to pass this legislation to 25. That would generate $9 million a year. Now you've heard, and I think that the trauma folks are being very ultra conservative. Again, the $20 million that Georgia uses used solely for their trauma network. If we pass this and generate $9 million, they just want $1 million. We could certainly fund that. We could certainly fund the EMT situation, but also provide additional funding for this rural hospital loan program. But one other thing I'd add to it is we have struggled to find funding. You know, we have so many unfunded mandates, but for AEDs in our schools, there's not a funding source for that either. So if we were to pass this legislation, then we could make significant investment in all 4 of these areas. Now, it passed out the Senate 32 to 5 to 1. Did not get a hearing in the House, which obviously disappointing. Hoping maybe this time that they'll change. But when I asked why wouldn't we consider this in Kentucky, the only excuse I got, and I would call it that, is it's not tourism friendly. Really? That's pretty weak. I mean, how many people plan their vacation on driving through states that have a super speeder bill? Certainly hadn't impacted Georgia any at all, and that's pretty weak. But again, if somebody's breaking the law to that extent, they deserve that kind of fine. So again, as we head in the 2025 session, I would hope that folks would give serious consideration. This is a funding model, again, for the Trauma Network, for Kentucky Rural Hospital Loan Fund, which again, in the legislation, I called for this to be named the Danny Bentley Fund in honor of him, but also AEDs for our schools and training for EMTs. Thank you all for being here. A great presentation. I'm sorry I couldn't give you more time because I think we could have talked about this for infinitum, but I thank you.
No, sir. Thank you, and thanks for having us. We gave out the information mainly as a background, so we didn't need to go through it. We just appreciate the chance
Great
to be here
job.
today.
Thank you. Appreciate it. Our last presentation today is Medicaid reimbursement rates for addiction recovery services. And I see we're going to start losing people here. As these folks come to the table, we have 2 proposed regulations to consider today. Are there any questions, comments about those? If not, then I'm going to assume those regulations stand as approved, as reviewed. Thank you. This was a late developing agenda item, and one that probably we will hear more about over the next several months. So I know there's 2 sides to every story. I've asked to hear from the providers today, and certainly we may be able to get an opportunity for the MCOs at a future point in time. But I just wanted these gentlemen to frame for you what the issue is and the problems it's causing for our Commonwealth. So with that, if you would, please introduce yourself for the record.
Good morning, Chairman Meredith and members. I want to thank you all for inviting us to present today. My name is John Wilson, and I'm president of the Kentucky Association of Independent Recovery Organizations. And I have with me today my colleagues Matt Brown from Addiction Recovery Care and Darren Bibb from StepWorks. And we're here to talk about long-term treatment, which is a good investment for Kentucky.
That it is. I appreciate you being here. And gentlemen, we have about 15 minutes for this presentation.
We'll roll through quickly, Mr. Chairman.
Thank you.
Just very quickly, this is a map of our footprint in Kentucky. We represent over 4,200 clients per day. We have 2,100 employees with substance abuse treatment occurring in 37 Kentucky counties. And we are focused on preserving access, raising quality, improving outcomes, and being good stewards of Kentucky dollars. With that, I'm going to turn it over to Matt Brown.
Thank you, John. Members of the Joint Interim Committee, thank you for your time today. Kentucky has made significant strides in access to treatment. It started in 2014 with the expansion of Medicaid benefits, and that created an avenue for Medicaid to pay for addiction treatment services. Kentucky was one of the first states in all of Appalachia to expand Medicaid and create a comprehensive benefit for all levels of care of substance use disorder treatment throughout our state. And because of this new access to treatment, Kentucky became known as one of the places in America that had the most reductions in overdose deaths. As a matter of fact, pre-COVID, 14 of the top 20 counties in the nation that had the largest reduction in overdose deaths were in eastern Kentucky. And then in 2019, there was an 1115 waiver passed that allowed providers to expand to more than 16 beds. And in 2023, Kentucky was found to have the most treatment access of any state in the entire country. So why are we here today? We're concerned about proposed rate cuts from the managed care organizations that are in process. Earlier this year, we began hearing about potential rate cuts that were coming soon. And keep in mind that Medicaid doesn't receive the same cost of living adjustments as Medicare. So prior to July 1st of 2023, substance use disorder treatment providers were doing the same care for nearly the same dollars since the beginning of the benefit in January of 2015. And we all know how much more expensive everything has gotten in the last 10 years. In March, some providers, including Addiction Recovery Care, where I work, received unilateral proposed contract amendments of 15 to 20% cuts from the Medicaid fee schedule from 3 of the 6 managed care organizations in the state. Other members of Kairos and other providers across the state have also received these unilateral contract amendments. We have every reason to believe that more cuts are coming, and I want to remind everyone that Kentucky's rapid growth to national prominence as being seen as a place where solutions are happening against addiction is because of Kentucky's commitment to long-term treatment and recovery. As recently as this morning, our patients are now receiving letters from one of the MCOs stating that their MCO will no longer cover addiction treatment services at ARC beginning September 30th. We do appreciate payers such as Aetna who've been focused on balancing care and stewardship, not just cost. Next up is this slide that I referenced earlier. This came from the National Opinion Research Center out of the University of Chicago and East Tennessee State University's Center for Rural Health Research. It compared 2 5-year time periods, 2008 to 2012 versus 2013 to 2017. And what they found is that 14 of the top 20 counties in the United States with the largest reduction in overdose deaths pre-COVID were in Eastern Kentucky. And some of the payers want to call ARC their biggest, most expensive provider, and then look at that map and say that the outcomes are the same as a 2-time-a-month Suboxone clinic. Anyone can look at this map and know who the largest and most comprehensive treatment provider is in Eastern Kentucky. So the question is addiction treatment a good return on investment for the state of Kentucky? 2 studies, one by Washington State Institute and another by the Robert Wood Johnson Foundation, show a clear return on investment for residential treatment. A $7 return on investment for residential treatment, a $5.28 return on investment for job training, and a $4 return on investment for medically assisted treatment. At ARC, we combine all of those to create a comprehensive opportunity for our patients that come through our program. Matter of fact, since January the 1st of 2020, we have been able to successfully hire 3,544 individuals who came through our program on Kentucky Medicaid, and they earned employment and became solutions in the fight against addiction. Over 500 of those individuals are still working with us today. If there was better data sharing, we could tell you where the other 3,000 went after they became employed at ARC. With these cuts, it could completely set back addiction treatment 20 years in our state. We strongly believe these are good dollars for the state to spend on helping people overcome addiction and be contributors to society. And one of our North Star metrics should be saved lives, and we are seeing that in Kentucky. Now I would like to turn it over to Mr. Darren Bibb, co-founder and CFO of StepWorks, to discuss how these potential cuts will impact the recovery ecosystem.
Thank you, Matt, and committee members. If these cuts take effect and they impact the recovery ecosystem, what's going to happen? These costs will not go away. They're simply going to shift. They'll shift back to emergency departments. They'll shift to the judicial system. They'll shift to foster care. They'll shift to homelessness, as we did before this benefit came online. This will likely result in higher overdose rates, higher recidivism, more ER visits, higher crime, and incarceration. Further, these cuts will reduce workforce participation through reduced access to treatment. We need to understand the full scope and impact of these proposed cuts to effectively advocate for those living in the counties each of you serve. We need a collaborative approach to treatment and recovery, allowing us the greatest chance of preserving access to treatment while improving quality and being good stewards of taxpayer dollars. Both managed care organizations and treatment providers have an important role to play in improving outcomes for people with substance use disorder. It was collaboration that expanded access to care in Kentucky. Further collaboration will find a sustainable path forward that preserves this access. So how do we do this? we must first start with data sharing. One managed care organization noted that they have a hard time reviewing the long-term effects of long-term treatment, given that they don't always have access to that patient's data through the full episode of care. We need data sharing arrangements across cabinets and the different stakeholders in Kentucky so that we can document the long-term value, getting people from addiction into the workforce. We must define and raise the standards of addiction treatment in Kentucky. We must continue to root out the bad actors by putting regulations in place, allowing them to take effect, and enforcing those standards to ensure that the most vulnerable Kentuckians are taken care of with dignity, compassion, and quality. Lastly, we must create an environment that incentivizes the entire continuum of care, not just episodic care. With treatment as the end goal, again, not just episodic care, especially with meth being such a prominent drug of choice in today's environment. We need good public policy. We need to expand access to evidence-based treatment and recovery services. Increased access to treatment will improve the health of our workforce, which will increase workforce participation and a stronger economy for Kentucky. Now I'll turn it back over to Matt.
Addiction is a brain disease. There are chemical imbalances and a rewiring of the dopamine pathways that occur with long-term drug use that make the brain actually look much like a brain suffering from Parkinson's, and it takes significant time, repetitive training, behavior modification, and a commitment to structure and experiential learning for the brain to properly heal. This is not completed or finished in a 30-day time cycle. It's also often not completed in twice-a-month sessions at a Suboxone clinic in an outpatient setting. Sometimes people need more than that, and we need it all in Kentucky. It requires education, repetition, long-term treatment, and when discussing the brain, we need to understand that it impacts the part of the brain that controls our decision-making. It impacts various brain receptors and affects the brain's primitive reward center, and we have to, at ARC and in addiction treatment, teach people that it is not just about surviving from their addiction, but thriving in our communities and being contributors. So long-term treatment is medically necessary for many individuals that we serve. Co-occurring mental health diseases and substance use disorders are often compounded by mental health and physical health conditions. Individuals come into our care with other needs such as diabetes, vision problems, dental issues, heart disease, infectious disease, hepatitis C, and more. And we must incentivize and ensure that Kentucky has a holistic approach that treats the entire person that's suffering from addiction and has programs that address the social determinants of health. Here's some data that we have pulled on our patient population. This is a sample size of 4,334 individuals that were discharged at any point in time in the year 2021. And what this graph looks at is what percentage of those individuals were arrested after treatment. This is using publicly available jail data. What percentage of these individuals were arrested after treatment, segmented out by how long they were able to stay in our residential treatment program. And you can see a wonderful downward trend line on the amount of arrests after long-term treatment. We've had payers tell us two different things. One is our success stories, some of our success stories, the ones who achieve employment and go off the Medicaid rolls, they fall out of their data sets, and so it's impossible for them to see the full benefit of what's happening. Next slide will show you this same exact trend line, and this is for ER visits within an 18-month time period after discharge. This is the same 4,334 patients that were discharged at any point in time in the year 2021, and you can see the longer someone receives treatment, the less likely they are to show up in the ER up to 18 months after treatment. And we know this saves the state dollars, and it also is a great benefit towards our patients that we're all serving.
Gentlemen, if we could, we need to wrap this up, and I think you've provided some great information, but I've got a couple committee members who have questions. I'd like to get to that so we can wrap this up for the next 5 minutes. Central Chambers Armstrong.
Thank you, Mr. Chair. My question, I was looking at page 3, your slide about return on investment, and you started to answer my question with your last slides, but I was looking and it looks like both of these studies are national studies, and they're from 2001 and 2006. And so I was just curious if you could speak a little bit about how you measure return on investment in Kentucky. I think you started to get at some of the outcomes you measure, but I'd love to hear about other outcomes and hear a little bit more about what we know about sort of how that translates into savings for the people of Kentucky. And again, I think you started to sort of touch on this with reduced arrests and whatnot, but what else, what other metrics do you all track?
So that's a great question. And so we track average length of stay because many industry studies point to the longer someone is able to and willing to stay in treatment, the better their recovery and life outcomes are. So we're very focused on how long is somebody willing to stay engaged with us. And to the point about a more up-to-date return on investment study, I believe that Kentucky has an opportunity to better share data across cabinets and across different sectors, and that feels like it's been a theme today. Actually, I've been in here since we started, and I feel like if there was an opportunity to share data better, we could really study the long-term ROI for individuals who are being treated for substance use disorder.
Thank you. Yes, I think it would be interesting to see in Kentucky what those numbers look like. So thank you for your answer. Thank you, Mr. Chair.
Can I answer one thing I didn't speak to? One data point that should be our North Star is overdose death reductions. In 2022, Kentucky was only one of 8 states in the entire country to have a reduction in overdose deaths. In 2023, Kentucky had a 9.8% reduction, and the nation had a 3% reduction. So we were more than 3 times the national average in reducing overdose deaths.
Thank you for that. Representative Rourke, you have the last question.
Thank you, Mr. Chair. You mentioned at the beginning of the presentation that ARC clients were receiving letters that MCOs would no longer cover the services. How many providers received or are receiving cuts, and what is the rationale for this?
I'm not clear on how many other providers, but I do know there are several other providers that have received these unilateral proposed contract amendments. And the theme that I'm hearing from the payers is costs. And we understand that bringing someone out of addiction and into a life of recovery and purpose and contributing to society, we understand that's very costly. Many of our patients have experienced generations of abandonment, neglect, trauma, poverty, addiction, mental health issues, etc. And so I think we find ourselves between a rock and a hard place of how much is this worth, and are the outcomes there to justify the return on investment.
Thank you. Excellent information. Again, I'm sure we'll have more discussion on this in the future, but appreciate the information you've given us today. Appreciate you being here. A couple of brief announcements before we adjourn. You may remember the University of Kentucky Healthcare is providing boxed lunches in room 125, and also they're providing tours of their new center in Lexington, providing shuttle services. And I'm sure if you go get your boxed lunch, they'll tell you where to meet that shuttle. Our next meeting will be Wednesday, August 28th, 2024. With that, there's no further business. We stand adjourned. Thanks, everyone, for your participation and cooperation.